Hello, everyone. Welcome to today's program called Navigating Schizophrenia Part 2, a path to stability using long-acting injectable therapy, or LAIs, expert insights. This is the second of a four-part series on navigating schizophrenia by putting emphasis on the continued treatment with long-acting formulations of antipsychotics in order to help patients achieve their goals. My name is Christoph Corell. I'm professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra Northwell in New York, and I'm also professor and chair of the Department of Child and Adolescent Psychiatry at the Charité University in Berlin, Germany. And I'm welcoming also two of my beloved colleagues, and let them introduce themselves. First of all, ladies first, Professor Perkins.
Oh, thank you, Christoph. Hi, I'm Deanna Perkins. I'm a psychiatrist at the University of North Carolina at Chapel Hill. I'm a professor in the department, and I direct early psychosis interventions in North Carolina, which provides consultation to the state of North Carolina about early psychosis interventions.
So very important to start early, and we'll talk about that too. And we're also joined by Leslie Citrome.
Hi, Leslie Citrome, clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York. I spent most of my career with the New York State Office of Mental Health in the state hospital system. So rather later in the course of illness for most participants with schizophrenia, and serve as a consultant to our assertive community treatment team in the county where I used to reside, do that remotely.
So we're spanning from the early phase to the chronic phase and need to actually use the tools that we have to the best of our abilities. And we'll talk about that today. The four things we'll be covering is the rationale and benefits for using LAIs versus oral antipsychotic treatments. What are the factors we should consider when selecting a long-acting injectable? Which patients may be good candidates? And we might actually rephrase that and say, are there any that are not good candidates? And it's hard for us, I think, to come up with them. And then if we think this is a treatment that everybody should know about, patients, but also clinicians, and that's why we're so happy that you're joining today's program, how do we then actually present LAIs to a patient? But let's first talk about what's unique and different and special about long-acting antipsychotics and why may we want to use them? Well, the problem with a chronic and relapsing disease like schizophrenia is that relapses are the main enemy on the road to recovery. Look at rheumatoid arthritis, maybe also multiple sclerosis. The first remission is usually what we target, and that's usually the best because the brain, the body are learning machines. You're basically repeating something that the body and the brain have learned. So the longer you're psychotic, the longer you're depressed or anxious, the easier it is to flip back. But not only the symptom problem occurs with relapses, but also how people see themselves. They identify themselves like, I am schizophrenic, rather than I have schizophrenia. It really invades the whole personality, the self-respect, their self-stigma, and the psychosocial realm is being eroded. It's harder for people to get back into their usual life that they had before. Diana, is that something that you see particularly in your early phase patients?
Oh yeah, you were just as you were thinking about it, I was thinking about a couple of clients I have right now that are or patients that are just just doing remarkably well, complete remission. And in fact, in our program, it turns out that most patients spend most of their time in remission during those early stages. About 90% of the time, these recovered first episode patients are in remission over those first 5 years. And the gains they make are remarkable, getting their lives back on track.
So they can, but once they relapse, less than you see them at the back end. What happens then?
Well, with every subsequent relapse, a little bit of brain goes away, and patients don't have the capability of returning back to their original baseline. And for some of our patients in the state hospital system, they become treatment resistant, and it becomes even more challenging to treat. And we end up using quite a bit of clozapine, for example, and When I think back to all the medicines that I've prescribed in my career in the state hospital system, clozapine was probably the most commonly used antipsychotic.
So the question then is, does it have to end there? And how can we prevent this deterioration of the illness course and also the restriction of life abilities and life engagement opportunities for our patients? And we know that with each relapse, as Professor Symptom said, some brain is lost. The longer the duration of the illness, the less gray matter there is, to actually fall back onto or use in order to go back to school or work, to get social interactions. And when you're sometimes off in a conversation, you are withdrawing because you feel you're basically an outcast. So we know that with each relapse, people lose grounds. There's higher rate of suicidality and committed suicide, especially in the first 5 years, because patients see that they're falling behind. They're not going to succeed and achieve what their friends, their cousins, their brothers and sisters are going to get in life. And then they become depressed, have poor quality of life, and are suicidal. So depression and comorbidity needs to be addressed at the same time. And there's also post-psychotic depression that sometimes can happen. At the same time, with each relapse, we're also making our treatments less effective, because most likely the illness becomes stronger. Biologically, it resides in the brain. So we know that the same medication is not as effective anymore. We need to use higher doses, and they're also not getting to the same effect. And we have more side effects with some patients, which then can fuel also non-adherence. And non-adherence is a complex issue, obviously, but it's part of the human condition. Have you been non-adherent? Any of you? Yes, we all have. And that is not having the cognitive problems that our patients have, not being ambivalent. Do I have hypertension or not? That's less asked than, am I really crazy? I don't want to take the medication and feel that I'm sick. Also, we might forget something when we have cognitive disability. There are negative symptoms that make it hard for patients to engage with the outside resources. But also, with each relapse, we know that it's very much related to not taking the medication. So one of the most reliable and predictable relapse predictors and risk factors is not taking the medication. That is, even taking the medication away when we think, oh, this is a first episode patient, they have done well, maybe they don't need it, or patients want to try it out. 500% greater risk of relapse when patients have not taken their medication anymore. And even short gaps can get you there. We've done a study in Finland showing that actually females were more likely to stop antipsychotics than males in the first episode. Younger patients that have more to gain and more to lose. Those that are shorter in the hospital, where we can't form a bond and maybe formulate a treatment plan that's helpful for patients. And substance abuse. We all know that from our care of patients. Patients add oil to the fire. They may even decide on the weekend, do I take your drug or my drug? And they know, you know what they're going to choose. The medication interest is lower than the interest in drugs. So even here, having a long-acting injectable that can bridge the gap, that can give you a seat belt, even when patients use drugs, where there's still enough dopamine blockade, can be extremely helpful. In other words, long-acting injectables in the studies that we have, in meta-analyses, pretty clearly show huge advantages, not over placebo only, but really antipsychotics that are given orally. It's harder to show in randomized trials because patients are selected to say, yes, I have the illness, of course, that give me the medication during the visit, I'm even getting paid for it. But when we did a very large mega-analysis of almost 400,000 patients in randomized trials, cohort studies where doctors and patients decide which treatment am I choosing, and mirror image studies before and after in the same patient, we were able to show that LAIs beat the oral antipsychotic the most even in the same patient. And that's what we do in clinical care. We don't compare one patient against the other. We compare the before and after. And what are the advantages? Based on the data, relapse prevention and prevention of hospitalization, which is often what patients say, I don't want to get back into the hospital ever and have those short needles in my backside against my will, 4 people sitting on me. Well, maybe you can avoid being here against your will. Also, there is better functionality, what patients often want. There are data that there's even better work attainment with long-acting injectables than with oral treatments. And guess what? Who wouldn't want to live longer? Mortality is also reduced, particularly in treatment-resistant patients with clozapine, but in non-treatment resistant patients, the best outcome was seen with long-acting injectables. And that should be woven into our discussion with our colleagues, but also patients and families, why LAIs should be an option. So let's hear from Deanna Perkins, what are the advantages from a standpoint of a provider, but also a patient, that LAIs should really be a first choice?
And I think from the clinician's perspective, it's just a no-brainer. That one of the main advantages is that we know that the person is taking the medication. And so if we see symptoms emerge, if we see any symptoms of signs of a relapse, we know that it is because the medication isn't working on the person, or there's other factors, substance use or stressful life events. But we know that it's not because that the person is missing doses of medication. And I think you talked a little bit earlier about most patients will miss medications for all kinds of reasons. It's just for whatever the illness. And so here we know that whether the medication is working or not. And then we also know that the dosage is, consistent too. So there's just no guessing with these long-acting injectable medications. We know what is going on in terms of medication adherence. So I think that's sort of the basic context about why clinicians like them, is because, it eliminates our guesswork, and then we can really work on what is the best strategy for managing these patients' symptoms. So it's also, I think, just easier. And that kind of feeds into what's great about these long-acting injectables for our patients. I remember in the old days, we used to think, well, long-acting injectables are like for people that don't want to take medications. That way we can kind of be, we're monitored and we know. But it's actually just the opposite, but long-acting injectables are just very convenient. There are lots of medications there are very few medications rather that are in a long-acting injectable formulation. And when they have them, patients love them because I don't have to remember to take a pill every day. I mean, that is such a hassle. And it's especially a hassle if, just say you're a young person who's trying to, who's going away for a weekend with some friends, and you forgot to take your medication with you. Do you think that person's going to not very many 20-year-olds I know are going to say, turn around and go back and get my antipsychotic pills, right? And so it just frees a person up from having to carry that medicine around, to have someone else discover it. It helps them keep their illness private. And it's just one less thing to have to think about. Christoph, when you were talking about how the pill itself can be a reminder of the illness, like every night you have to take your antipsychotic medication, does that mean that I'm sick, right? Well, no, it means that you're well, but you can see why a person would kind of go down that line of thinking. And so it really is, it actually frees up a person in terms of their autonomy, that they are making a choice that they want to take this medication for the next month. I'm not saying they have to take it forever. This isn't a commitment to take a medicine forever, but you want to take it for the next month, just go ahead, and here's an easy way to do it. And you don't have to think about it anymore. So I think that's when framed that way, our patients really start to embrace it. Now, if we have this attitude that, somehow this long-acting injectable is a punishment or the last resort, our patients pick up on that. And so I think our first job is really to think about it and convince ourselves, if I had that option, what would I go for, right? Would I want to take the medication in an easy formulation, easy to remember? Or, do I want to have to take a pill once, twice, 3 times a day, whatever it is? And that's what I mean. It's kind of like this no-brainer. It's easier. So I think this fits in with patients' perception of having control over their illness. So if clinicians can convey that attitude, that they can kind of embrace that idea and then convey that attitude to our patients, patients say, yeah, great, it's a good idea. So, but I think we do have to understand that this is a way that patients have control over managing their own illness. It increases autonomy. It supports them on their recovery, right? This is what can help people do better. And that's what the data shows that Christoph was just showing, right? That these patients that are on these drugs, the long-acting formulation of the same drug do better. And it's because it's easier and more consistent.
It's funny that really long-acting injectables have been seen so much only as a last resort, and they've been stigmatized, although they can be used to destigmatize the illness. And we're somehow losing an opportunity here. And we have to almost rebrand and reframe long-acting injectables, and then hopefully change the perception, not only in patients, but particularly in providers that can then present this in a certain way. And so, Les, what would you recommend? How does the audience go about it? How do we think about long-acting injectable and how to match them with patient goals?
Well, probably the biggest obstacle to the use of long-acting injectables is us, right? Not us in particular, but us in the way of the medical profession. And we just don't offer it. The American Psychiatric Association guidelines for the treatment of schizophrenia recommend the use of LAIs not only for those with poor or uncertain adherence, but for those who would prefer such a treatment. Well, how do we know they prefer such a treatment if they're never offered? And I tell providers, our patients with schizophrenia in some ways are lucky in that they have their medicine available as a long-acting injectable. I sure wish I had my antihypertensives available as a long-acting injectable. And for those of you in the audience who have hypertension, how much of a hassle is it to take one or two antihypertensives? And how often have you forgotten to take the pills from your pill box and wondering how they got in there? And why are there extra pills in the pill box? Well, we forgot. And having an LAI eliminates that uncertainty. And before I get into how to select which LAI, I want to give a shout out to the families. It's a very big stressor when your loved one has uncertain adherence. And you end up having conversations like, did you take your medicine? 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 It's extremely stressful for everybody. Having an LAI on board means guaranteed delivery, and you don't have that conversation. Did you take your medicine? Did you take your medicine? Did you take your medicine? And actually, family members feel better in better suited to help their loved ones with their illness. So that's been established through surveys as well. So how do we select one? Well, basically we think of, well, what were they on and did it work? Did they tolerate it? And are they willing to take that molecule? And so that makes that decision easy. But what if you're starting somewhat fresh and they've never been on that molecule before? You want to make sure that they tolerate it, that they're not allergic to it. You also want to have some sense that they would respond to it. For acute use, we do have a selection of formulations that do not require oral supplementation, that get you plasma levels right where you need it to be right on day one. So that would be my preference there. But all of them have been studied more or less in acute treatment as well. So I don't let that stop me. For maintenance treatment, it's much more straightforward, of course. Ultimately, we're going to think of, should I give a first generation LAI or a second generation LAI? And I've encountered this in my consultations with the assertive community treatment team, where there's legacy use of haloperidol decanoate and fluphenazine decanoate. And unfortunately, that's often accompanied by other things that become necessary, like benztropine, which is undesirable. So I try very hard to get patients onto a second generation LAI, of which we have basically 3 different families presently. The risperidone paliperidone family of LAIs. So that would be risperidone microspheres was the first one. We have paliperidone palmitate. We have a risperidone subcutaneous now. And for those who are listening, you know that paliperidone is the main active metabolite of risperidone. And then we have a couple of aripiprazole long-acting injectables to select from. And then we do have this olanzapine pamoate presently, but that requires an observation period after each injection with a REMS, so that's not well adopted. But perhaps in the future we'll have a different formulation of olanzapine subcutaneous. But how to present this is basically using all our skills in talking about the benefits for the patient, as well as sort of demystifying the process and get the patient to be in the driver's seat here. So first off, I normalize non-adherence. I say that everyone who has an illness misses a medicine now and again, whether you have diabetes, hypertension, asthma, or depression or schizophrenia. And we can't fall into the trap of thinking, well, our patients are adherent. It's the other person's patients that are non-adherent. Well, fact of the matter is, all of our patients are at least partially non-adherent for the most part. And then when we introduce the idea, how would you like to get your medicine once a month or every 2 months? How does that sound to you? Then it may sound very intriguing until they hear that it's about a needle. I don't like needles, is the response. Then we have a conversation about that. Well, it's like that flu shot that you got. Or let me show you the needle. Let me show you the size of it, because they may think it's like this big. They may have misperception. Or I don't want a shot in my butt. And they have the misperception that they have to drop their pants, which is actually false. It's the upper outer quadrant of the gluteal muscle that where we inject the LAI in, or the deltoid, or for the subcutaneous, the back of the arm. And then I talk about what they're looking for in terms of their treatment. They don't come to me for their treatment of their hallucinations and delusions. Their delusions are very real to them. Their hallucinations are very real to them. What they come to me for is everyone is hassling them. They can't get a job. They can't live independently, and they end up in the hospital, and they don't quite understand why. And my goal with them is to find ways to keep them out of the hospital. So the ACT team spends quite a bit of time supporting people in terms of housing and employment as best they can, having things to do during the day that avoid things that could be harmful to them. I involve as many people as I can, so the family is really key here. They are your best ally here with the LAI. And then lastly, when I present it, I don't expect them to say yes right away. I mean, it's great when they do, but it takes time. And hearing this story, if I can engage them in a conversation and say, you don't, have to make a commitment. It's not forever. You want to try it. We can stop it the next go around. If you want to think about it, that's okay too. And, there's someone I'd like you to speak with, and that's the peer advocate who has lived experience with the illness and perhaps with an LAI, who the patient may listen to more thoughtfully than us. So I try to marshal all those resources. Ultimately, patients may say, I don't need medicine. And then it becomes, well, what can that medicine do for you? And it's useless to talk about, well, it reduces hallucinations and delusions, and that would be better for you. No, they keep you out of the hospital. They may say, I take my meds, don't you trust me? Well, it's not about trust, it's about human nature. And I share with them my own struggles with adherence with antihypertensives. I humanize it. And then patients may say, I want to have control whether taking my meds or not. And then it's really education about keeping symptoms away, and that even missing 1 or 2 days a week can lead you down the wrong path there. And this is true for any chronic illness. So this requires some finesse. It requires some skills with motivational interviewing and shared decision making. But I have some advice for those of you who don't know anything about motivational interviewing. The more you learn about it, the more you'll use it, and not only with your patients, but with your friends and family. And getting people to do something you would like them to do, it always is worthwhile getting them to come up with the idea and to own the decision. Then they're more likely to adhere to that decision. It doesn't work to say to someone, you do this, you do that. Think of the last time you told a 2-year-old to do something. Did that work out? No. It's human nature to be somewhat oppositional when ordered to do something. So it's always best to get them to that point where they want something, that you've made it so compelling. So that in a nutshell is the strategy there. It's not about symptoms. It's about getting patients in the recovery mode, getting them to where they want to be, whether it be independent living, a job of some kind, more interactions with others, a boyfriend, girlfriend, being able to interact with others.
Yeah, and I think I love what you're saying, Les, and it's also, I was thinking about how that's part of why it's so important to talk about alternative formulations from the very beginning, right? This is a medication. We'll start you on the oral form to see if it works for you. And then if it does, you have the option of a long-acting injectable. And which means that you only have to take the medicine once a month or maybe even once every couple of months. So, and then just leave it at that, right? That they now have that information. And then we'll see how that medication works. And just kind of weaving that in, right? Is that this is an alternative drug? Maybe there'll be some advantages for you. What could they be? And having them come up with what they don't like about taking a pill, and maybe the long-acting injectable is a great option.
So it sounds to me that the different formulation of the medication needs also a different formulation of how to present it to patients. And that would mean that we try to first learn something about them before they learn something about the medication. What is it that you want in life? Okay, so you want to stay in the basement with your parents and not be thrown out. Well, last time you got really, really sick. What happened? Well, they called the police and were really scared of me. How could that have been avoided? Why did that happen? I didn't really take my drugs so much. So, I took some drugs, but that wasn't what was in my toolbox. So to let them put two and two together and then say, well, maybe in order to get what I want, I have to then take this, what you think I should take, but I don't want to do it every day. Well, here's an option. Why don't you try it once a month? And what you said, Les, also people who have walked the walk and don't just do the talk, that they can also talk to other patients who may say, I hated this in the beginning too, but look where I'm now. I actually have a little job here and I'm doing fairly well. And I didn't have to go back to the hospital, which I did before. I was homeless. And do you want to go that path or that path? So let me bring up maybe for the last couple of minutes, each of you, what has been a problem or a challenge offering LAIs? And how have you overcome that so that the audience can learn from that? Maybe, Deanna, you want to start, and then Les, and then we wrap up.
I'll say the major issue is I don't like shots. And, they can kind of see the advantages. And if it was a pill they took once a month, it's a little easier. And one thing that I've offered them is a little bit of, xylocaine cream on a little Band-Aid. And I say, you know where you're going to get the shot. You put that on a half hour before it, I guarantee you will not feel this, right? That this is very effective. And so, if it depends on how your clinic situation is, but if someone they know can be with them and kind of working through that first step where it really will not, this is not a painful thing, right? And then you distract them and then they don't even know they said, that was it, I got the shot. So having a way of, yes, I understand, I don't like shots either. So is it worth it or not? But to have that discussion around that point, yeah, sure. It's not that I get excited about having a shot, but in the end, it's just a lot easier, and we can do it this way with this medication, and you won't even notice. You won't even notice it when it happens.
Plus, we can also tell them how low the pain ratings were in the studies, and that there are even subcutaneous injections now where people feel very little. Les, any barrier or obstacle that you have encountered, and how have you overcome that?
Well, sometimes patients have a bad experience in the emergency department when they're held down by 4 people and get a shot. And we have to explain this is not that kind of shot. This is something that you voluntarily accept in order to better control your illness. This is very different from when you were out of control. And then I do try my best to demystify it, as I mentioned before, where it's actually injected. You don't drop your pants, for example, and it could be given in the arm or back of the arm if it's subcutaneous. I also like to mention that these new ones are different from the older ones that they may have had experience with. Because the older First generation LAIs are all based in sesame seed oil and can be quite painful to receive. These are water-based, or the subcutaneous injectables is a polymer, so a whole different experience. Plus, they won't have that drug-induced Parkinsonism or dystonia that they may have associated with the older drugs. These new ones are much better tolerated.
Wonderful. Thank you so much to both of you. This was a healthy and wonderful discussion. And thank you all for watching. Please scan the QR code to claim your CME credit. And we have another program for you tomorrow, same time, this time with a patient advocate. We've talked about that, learning from patients, and Professor Citrome will also be there. And we hopefully can further elucidate and also help you to utilize LAIs in your practice. Thank you, Les. Thank you, Diana. Thank you all, and see you tomorrow.